Good morning. Hello and welcome to the Wednesday morning rounds. Today's speaker is Dr. Graeme Prosperi-Porta. He's a fellow in our interventional cardiology program. Very exciting topic today. You talk about stopping anticoagulation in AF patients, which is kind of a dream coming true in the light of current studies. Thanks, Graeme. Quick announcement, please don't forget to fill the attendance form at the back of the room. Thank you.
All right, thank you very much. Yeah, so stopping anticoagulation for many patients is a dream. For a large proportion of them, it may still stay a dream, but you'll decide at the end of this talk. So I have no disclosures. This is my agenda. I have a selfish a public service announcement to push a study that I'm involved with. We're going to talk very briefly about stroke prevention and atrial fibrillation. We're going to talk about different strategies called burning the heart, plugging the hole, maybe a bit of both, and then one final research-related public service announcement for my structural bosses. So right now, some of you know, we're doing a research study in the emergency department called the LA Clotted trial. So atrial fibrillation, it's a very common arrhythmia. It accounts for about half of all emergency department visits. And in the US specifically, about half of patients are admitted to the hospital, which, is not the Canadian context. I think the emergency physicians, especially in Ottawa, are really good at treating this. But just in Ottawa itself, about 80 patients per month visit the emergency department with primary atrial fibrillation. 25% of them can't be cardioverted. 15% end up getting the consult resident to see, and 10% of all of these patients, so 8 per month, get admitted to hospital for management. Those aren't huge numbers, eight patients per month. It's not a lot. But, especially in Ottawa and in Ontario, our hospitals, our emergency departments are overrun. And so this is really a healthcare utilization problem more than anything else. So we've designed the LA Clotted trial, which we're using CT to clear left atrial appendages when we can't immediately cardiovert patients. We've been doing it here at the Heart Institute for a long time. We did our initial trial as an inpatient and showed that it was safe and effective. And so what we've done is we've created this study really for emerge docs to use this technology. Right now we have one site up and running. We've randomized 50 patients just here at the Civic campus over about 10, 11 months. We have 2 other sites in Ontario that are going to be up and running in the next kind of several weeks to months, one in the US and hopefully one in Alberta. The way that we're doing it is a patient comes in, very pragmatically, the emerge doc can't cardiovert them. They get randomized to usual treatment or CT, rule out a clot. They go back to the emergency department and they get cardioverted. It's crazy. I've never seen emergency physicians so excited about anything. Like they love putting patients. There's a few of them that get really excited and tell me how excited they are every time that we enroll a patient. And I can tell you, I can't tell you the results yet, but I can tell you that it works. The emergency doctors like it. It's definitely going to be a positive trial, more for healthcare utilization. And we've designed it with a win ratio to help reduce sample size and really focus on kind of these patient-centered outcomes, hospital admission, repeat visits to the emerge, and quality of life. So my kind of plug here is you guys get calls, especially if you're the staff on Blue Team. The residents all know about this, but sometimes they forget. They're really busy. So if you get calls about patients or they call your clinic or you see them on Orange Team, on consults, try and think if they're a good candidate and refer these patients to us. Richard Jung is going to be taking over from me. He's been instrumental. He's found so many patients for this study, and he's been really helpful. So call us, talk to a resident. They all know about it. They can get you in touch with us. So I'm going to talk about now just very briefly atrial fibrillation. So it's the most common arrhythmia worldwide. And the you're probably wondering, why is a interventional fellow talking to you about atrial fibrillation? He's not an electrophysiologist, but I think it doesn't matter what area of cardiology you're in, or medicine for that matter. You're going to deal with patients with atrial fibrillation. You're going to have to counsel them, decide on treatments. And so it's really kind of the disease of every single cardiologist. So worldwide, a few years ago, they estimated about 50 million people live with atrial fibrillation. If you're in Russia, you have a lot of it. If you're in Canada, a little bit less. And it's this kind of multifaceted approach to care. There's the stroke risk aspect, there's the symptom management aspect, and there's all of these little risk factors that go into increasing your risk of atrial fibrillation, your burden of atrial fibrillation. And so it's, we're often siloed into, the EP focus, the interventional focus, but you really want to address all of these risk factors: alcohol consumption, hypertension, diabetes, making sure people are exercising adequately, making them stop smoking, treat sleep apnea, help them lose weight if they're overweight. The biggest problem and biggest fear with atrial fibrillation is the risk of stroke. So as you're all aware, atrial fibrillation increases your chance of having a cardioembolic stroke. And, we all quote to our patients, 90% of strokes come from the left atrial appendage. And this comes from really old data, not looking at stroke, but actually just patients who either had surgery or had a TE, often perioperatively, and they looked at, if there was a clot, where was that clot? And 90% of the time the clot was in the left atrial appendage. And so we've kind of translated that into our discussions with patients, that 90% of clots come from the left atrial appendage that cause stroke. And so you need to be anticoagulated to try and reduce that. That only holds true in non-valvular atrial fibrillation. The valvular or rheumatic atrial fibrillation is a different beast. The clots come from many different areas, not just the left atrial appendage. And so that's a totally different focus, and there's not a lot of research in it. You take warfarin, and unfortunately that's kind of it. So when we think about reducing the risk of stroke in patients with atrial fibrillation, there's a ton of research that's been done. A lot of it was in the era of warfarin therapy. And so, I think that probably our risk has, been maybe a little bit overestimated, and now is changing. So there's probably about 30 different risk scores looking at your risk factors and how they translate into the development of strokes. We know that the left atrial function, left atrial size, changes your risk of forming blood clots and strokes. And there's been lots of research in that. And also something I think is really fascinating is the morphology of your left atrial appendage. To me, it's like a fingerprint. Nobody's left atrial appendage looks the same. They're all different. And we've sort of categorized them into these different shapes, with the chicken wing having the lowest risk of stroke, and the cauliflower shape with all of these little pockets having the highest risk of stroke. We don't necessarily use that information on a kind of a clinical basis, but it's something that is really important when we're doing left atrial appendage closure. The treatment for atrial fibrillation in terms of anticoagulation and stroke risk has really, in Canada, been focused on the CHAD 65 score. So if you have any of the CHAD's risk factors, or you're above 65, you should be on an anticoagulant. That's probably the more aggressive approach, and that's what we do in Canada. In the US, they use a CHADS VASC score. So in men, if your CHADS VASC score is above 2 or more, and in women, if your CHADS VASC score is 3 or more, they say you should be anticoagulated. There's a bit of a gray zone. If your CHADS score in men is 1, CHADS VASC in men is 1, CHADS VASC in women is 2, they can say you can consider anticoagulation. It's reasonable. And so that's one slight difference between the US and Canadians. All of this CHADS VASC, CHADS scores were really developed in the era of warfarin, and we know that has changed now. We've had numerous trials that have shown that direct oral anticoagulants are superior, better to warfarin with the primary endpoint of bleeding. But as you all know, we encounter this countlessly, whether you're in the clinic or you're on consults. The problem with anticoagulation is that people bleed, and people don't like taking it. You know, patients go for procedures, they go for surgeries, they go for colonoscopies, and there are these periods of time where they're not fully protected. And we know that observational data has showed us that if you're on a suboptimal dose of anticoagulation or you're not taking it, you're going to have increased risk of events, mortality, and stroke. And so, patients look at this, patients are worried, and they are sitting in front of you in the clinic and they're telling you all of these things. They don't want to be on blood thinners. They don't like taking pills. They had an ablation, their atrial fibrillation is cured. How long do I have to take this blood thinner for? My family doctor said I could stop because my iron's been low. I want one of these Watchman devices. My friend got one of those. So you get these questions. I think everybody does in the clinic. And so I want to kind of pick apart and talk about a few of them more specifically. So the first one, I had an ablation. My atrial fibrillation is cured. Why do I still need a blood thinner? And until recently, we didn't have any data for this. There was some observational data that suggested that your stroke risk was lower after an ablation, and maybe you could stop it. So there's been two studies. The first I'll talk about is the Alone AF trial. It was done in South Korea, had 18 hospitals, and they did a randomized trial 1-to-1 to discontinue your DOAC or continue your DOAC after you've had a successful AFib ablation. Over about 3 years, they randomized over 800 patients, and their inclusion criteria was if you had a CHA2DS2-VASc score of 1 or more in men and 2 or more in women. And the way that they determined whether you were arrhythmia-free, and I think this is important if you're ever going to implement this, so they did at least 2 24 to 72-hour Holter monitors in the year after the ablation, and 1 Holter monitor had to be within 2 months of randomization. So to be honest, not very strict, especially if you have paroxysmal atrial fibrillation, it's going to come and go. So if you implement something like this in your practice, you'd have to decide, what's your threshold to truly prove that there's no atrial fibrillation? And does that matter? I don't know if we have the answer to that. I think the exclusion criteria are really important. So they excluded anybody who had really structural heart disease. Obviously, anyone with bad kidneys can't tolerate a DOAC, need to be on a DOAC for another reason, VTE. And what they did was every 6 months, they did a very short Holter to look for recurrent atrial fibrillation. And their primary outcome was the first occurrence of stroke, systemic embolism, and I bolded it there, or major bleeding. So they've taken a kind of efficacy endpoints, stroke, embolism, and they've merged it, combined it with safety endpoints, which we'll talk about a bit more. So their trial, you can see it's a relatively low risk population. These are patients who are in their 60s, over two-thirds were male, 2/3 had paroxysmal atrial fibrillation, and the median CHA2DS2-VASc score was only 2. They had a left atrial diameter of 40, which is generally like just barely mildly dilated. And their ejection fractions were in the 60s. So pretty well normal hearts, relatively low risk patients. You can see the spread of CHA2DS2-VASc score. So the predominance, the majority of them, 1, 2, there were some 3, and very few CHA2DS2-VASc score above 3. In their monitoring, both clinical, you develop palpitations, and their intermittent Holter screening, they found about 10% of people had recurrent atrial fibrillation in the follow-up of 2 years. I think that that's kind of in line with kind of AFib success rates. So they probably had pretty good ablation. What they showed, as you can see here, so their composite of stroke, systemic embolism, major bleeding was favored no anticoagulation. This was really driven by bleeding events. You can see it's sort of counterintuitive, but they actually had more stroke in patients who continued their anticoagulation. And there was some hemorrhagic, but really not driven by hemorrhagic stroke. So, really low event rates, which probably reduces our power to know, is this a true finding? Is it a true signal? Or is it just by chance? I think it's probably by chance. And so, the conclusion that I take from this study is that if you have a successful atrial fibrillation ablation, stopping your DOAC reduces your risk of bleeding. But I don't think that we can conclude based on this data that it necessarily changes your risk of stroke. In this study, we saw a really low risk population. Their annualized risk of stroke in the population that stopped and that continued their anticoagulation was less than 1%. And they had this kind of muddy endpoint that was really driven by this bleeding safety endpoint. And I think it was underpowered for knowing, the effect on stroke. The next study, really well done study, was the Ocean randomized trial. This was spearheaded out of Montreal and Ottawa. Dr. Burney did this study. And so this was a randomized trial 1-to-1 of DOAC therapy or aspirin therapy after you had a successful ablation. They randomized over 1,200 patients, and they had a very similar inclusion criteria. CHADS VASc greater than 1 or more in men, 2 or more in women, and the patients had to be arrhythmia-free for the year. They did this similarly with Holter monitors 2 to 6 months after ablation, and then 1 48-hour Holter within 2 months of enrollment. They excluded patients with bad kidneys, obviously can't, higher risk with the DOAC, anyone with valvular atrial fibrillation, contraindications to atrial fibrillation, having a stroke, a disabling stroke within the last year or within 14 days, and if they had a hypercoagulable disorder or had intracranial anomalies, or if you were over the age of 85. Their endpoint, I think, was a lot better. They looked at stroke, systemic embolism, and also covert stroke detected by MRI, which is defined as a new infarct greater than 15 millimeters in size. So you can see very similar population, patients in their 60s, over 2/3 were male, predominantly paroxysmal atrial fibrillation. You can see the spread of CHADS VASc score, predominantly 1 to much less, 4 or more. They had normal LVs. They had very mild left atrial dilation. I didn't see how many patients had recurrent. They didn't do any monitoring as part of the protocol, but a number of patients similarly, kind of 5% had a repeat ablation. So you can imagine those patients had recurrent atrial fibrillation. What they found was that their primary composite outcome of stroke, systemic embolism, new covert embolic stroke was no different between the two groups, the aspirin and rivaroxaban. A little bit higher numerically with the aspirin group, but not significant. No difference when you look at the stroke, and also, interestingly, no difference in covert embolic events. When you look at the primary safety endpoint of fatal bleeding or major bleeding, really no difference between rivaroxaban and apixaban. So I think similarly an important study that gives us some insight. There's still unanswered questions in this study. Similarly, the annualized stroke risk was less than 1%. There's no routine post-enrollment monitoring for recurrent atrial fibrillation, which I think is really pragmatic. Maybe missed an opportunity to understand, is it the ablation that changes your risk, or is it the fact that your atrial fibrillation doesn't come back? This was a really low risk population at baseline, and the MRIs are really reassuring that we're not missing patients. I think this study was still underpowered for stroke. They would have needed over 10,000 patients to adequately power it based on their event rate. So my take home, in patients with a CHADS VASc of 1 to 3, Definitely not more than 3, and they have a structurally normal heart, who's had a successful catheter ablation. I think these are patients where you can discuss with them the pros and cons of discontinuing their anticoagulation. I would, based on the data that we have so far, I'd be really cautious in patients with a CHA2DS2-VASc greater than 3. Maybe there will be some patient level meta-analysis from these 2 studies that will give us, more data, more insights, whether it's safe. And I wouldn't do it. Most of the patients that I see have structural heart disease, and so I don't think I would apply it to patients with big left atriums, with structural heart disease, with valve disease. And I think, in my mind, there's still some unanswered questions. I can imagine you're following a 64-year-old who you've done a successful ablation on. There's no more AFib. You stop their anticoagulation. Does there come a time in their life where they need to restart their anticoagulation? Or is this a permanent fix? If they develop more risk factors, is it just when their AFib returns? I don't think we know that. Hopefully longer follow-up will tell us. All right. So the next thing, I think this happens more in the United States, less in Canada. We don't have billboards like this. But a lot of patients are interested in getting their left atrial appendage closed. They have friends who have done it. They saw a billboard when they were in sunny Florida. So left atrial appendage occluders, they've implanted over 600,000 Watchman devices worldwide, predominantly in the US. The market is huge for this, $5 to $7 billion by 2030. And it's really appealing to patients. Patients, often want to have they don't want to be on blood thinners, as you've already heard, as you hear your patients tell you. They want that single fix. They don't want to have to worry about it anymore. And so many patients, especially in the US, go for this. We first started doing left atrial appendage occlusion in the era of warfarin. And so there were a number of trials that gave us some data compared to warfarin that told us that your risk of major bleeding was lower when you put in a Watchman, obviously because you're not on anticoagulation. Your risk of ischemic stroke was probably a little bit higher, and your risk of hemorrhagic stroke was a bit lower. The problem with these trials, as I just said, is that they were compared to warfarin, and warfarin is no longer the standard of care for atrial fibrillation. And so they did a very small trial looking at DOACs, and they took a really high risk population, and they showed in this kind of combined efficacy safety endpoint that left atrial appendage occlusion was non-inferior to DOACs. Small study, only 400 patients, really high risk. So this has not translated into kind of widespread practice. The American guidelines, the SKY 2025 SKY guidelines, based on the totality of data kind of up until that point, tells us that in patients with non-valvular atrial fibrillation, they have a contraindication to oral anticoagulation. Left atrial appendage closure is better than nothing. They also give this sort of statement. They don't give any kind of certainty or strength of recommendation. They say in patients with non-valvular atrial fibrillation who have decided to pursue stroke prevention treatment, which is the majority of patients, oral anticoagulation or left atrial appendage occlusion are treatment options. One is not better than the other in the guidelines. I think right now the data tells us that oral anticoagulation is kind of primary frontline. But that massive market resulted in a number of trials which I think are important for us to go through. So the first was the Closure AF trial. It was investigator driven. It was a 1-to-1 RCT of left atrial appendage closure versus medical therapy. And that medical therapy was kind of whatever the best treatment was for that patient. Over 900 patients got randomized at 42 German sites, and they included a higher risk population. So they took patients with a high stroke risk, CHADS 2 or more, and high bleeding risk, so a HAS-BLED 3 or more, or prior intracranial, intraspinal, intraocular hemorrhage, BARC 3 bleeding, significant CKD, or recurrent bleeding episodes. They excluded people with bad kidneys, with valvular atrial fibrillation, if they had a contraindication or another indication for anticoagulation. They designed it with a non-inferiority margin with a hazard ratio of 1.3. And they use this, again, I'll call it kind of a muddy endpoint composite of stroke, systemic embolism, major bleeding, cardiovascular unexplained death at 3 years. You'll see it's a much higher risk population. So these patients are over 75. Their mean CHA2DS2-VASc score was 5. Their HAS-BLOOD score was 3. And many of them had prior events. What they found, they include, so one important thing, they included peri-procedural bleeding in their endpoint. And what they found is that they did not meet the non-inferiority margin for medical therapy versus oral versus left atrial appendage closure. I think some things we can learn from this. One, procedures come with risk. The other thing I'll point out here, the ischemic stroke was about the same in both groups. Major bleeding was similar in both groups, and that was major non-procedural bleeding. And you'll see stroke or systemic embolism there as well, very similar. It's small here, but you can see that there's complications, there's risk to procedures. So tamponade happened in 5 patients, major bleeding requiring transfusion at the time of the procedure happened in 18 patients. One patient had the device embolized and had to be surgically removed. One patient had a TIA, and 2 patients died within 7 days of implantation. So these are, they should be relatively stable outpatients that you bring in for a procedure, and these are things that happen. So I think the things that I take from this study, optimal medical therapy in patients who can take an anticoagulant is highly effective. The procedures that we do for people have risk, and that risk is critical in patients who are stable outpatients. It's different when someone comes in with a STEMI, you're forced, but these are patients who are otherwise well walking around. Overall, the study is still quite underpowered. But at the 3-year, the stroke, systemic embolism, and major bleeding risk seems about the same. What I don't know, you've taken all of that upfront risk for the procedure. What I don't know is now that procedural risk is gone, are we going to see these curves cross over where you accumulate more bleeding events, because that's just what happens when you take a blood thinner, and now you're protected from stroke kind of permanently versus the patients who have to stop for procedures. And so longer term follow-up, I think, will be important for this. As I mentioned, procedural risk happens. When we do left atrial appendage occlusion, we tell patients that there's risk of death, there's risk of stroke, there's risk of us accidentally injecting air into their heart that can cause stroke, cardiac arrest. One of the more common and serious risks is pericardial effusion, and these devices all have these little spikes that hold on to the left atrial appendage tissue, and those can poke through and cause pericardial effusions. These devices aren't yet perfect, they're getting better and better. These devices aren't made to fit in that single person, and so you can have leaks around the device, which makes them ineffective if you have significant leaks. These devices can cause blood clots, or can develop blood clots on the device as it's healing, and that's a problem in and of itself. So, these are things that I counsel patients on when they come for a consultation for a left atrial appendage occlusion, and it's, often patients come in with, oh, this is a 1-to-1, I'll get the appendage, I don't have to take this pesky blood thinner that's making my arms bruised. And often when they hear about these risks, their thoughts often change. And this is just one patient. So this was a patient that we attempted to do a left atrial appendage closure on probably 2 or 3 months ago. You can see that their left atrial appendage on the right in the 135 view, it's relatively shallow, so not the most straightforward or easy appendage to close. We tried with 2 different devices, and in the 135 view on the right, this one, that kind of funnel shape, our device, this is an Amplatzer device, kept popping out. We could not get it to seat properly. So we switched, we tried a Watchman device. And you can see, this is the fabric, there's leak around it, it kept popping out. So this wasn't sealing as well. We tried numerous deployments, numerous sizes. And then we started noticing that there was a little something, this little mobile echo density here in the left atrial appendage. And when we saw this, despite our ACTs being well above 300 for the entire case, we decided it was time to get out of there. Unfortunately, when the patient woke up, they had neurologic deficits. Their left side of their body couldn't move, and you can see these numerous kind of cardioembolic shower strokes. So periprocedural complications, they happen. You hope that they happen when the benefit is great enough to take those risks. And so in these stable patients, it's a long discussion with them in the clinic to make sure that they truly understand this and this is the right thing for them. So, there's only, in my mind, two ways to eliminate periprocedural risk. One is to not do the procedure. And the other is to kind of downplay it in the trials to get rid of it. So the reason I bring that up, so a more recent larger study, Champion AF, was just presented at ACC. This was, I think it's important, an industry-sponsored randomized trial that randomized patients 1-to-1 between left atrial appendage closure and aspirin versus continuing their oral anticoagulation. They had 3,000 patients at 141 centers worldwide, and their inclusion criteria similar to the last study, CHA2DS2-VASc men 2 or more, women 3 or more. They excluded patients who had a recent MI, stroke, TIA, major bleeding event in the 30 days before enrollment, and they had some other renal exclusion criteria. They designed it as a non-inferiority trial using an absolute margin instead of a relative margin. They used an absolute margin of 4.8%. Their primary endpoint was a composite of death from cardiovascular causes, stroke, and systemic embolism at 3 years. So a good endpoint. So, I think this speaks to the devices. Almost 99% of patients that were in the trial had a successful device implant. What's interesting is those patients, they reported only 76% were adherent to their medical therapy. These patients are they didn't describe exactly what this was, but these patients are anticoagulated either with dual antiplatelet or more commonly back on their oral anticoagulation for a period of time after the appendage is closed. Only 76 were adherent to that. In the DOAC group, 87% were adherent to medical therapy. And, I think that this is a little bit lower than most of our patients, but it's in line with what's reported. And they allowed patients to cross over after they had an event. So 206 DOAC patients crossed over, many of them after event. Some, a lot of these sites were in the US, and so you just go to another center if you want your appendage closed. Patients were a little bit over the age of 70. Their mean CHA2DS2-VASc score was 3.5. More patients with a CHA2DS2-VASc of 3 and more. Many of them had paroxysmal atrial fibrillation, and a large portion, almost half, had a prior atrial fibrillation ablation. So what they found was that their primary endpoint of cardiovascular death, stroke, systemic embolism met their non-inferiority margin. You can see that stroke, projects there, you can see that stroke in the closure group is numerically higher. So there were 50 stroke events versus 33 stroke events in the anticoagulation group. So this is a signal. I don't think anyone thought that left atrial appendage closure would be necessarily as good or better for stroke prevention. in the short term in these patients, but you can see there is kind of that signal. It's not significant, but there's that signal that maybe there's more stroke in patients who get left atrial appendage closure. When they looked at their kind of safety endpoint of non-procedural bleeding, they showed that there was a reduction in patients who had the device. When you combine procedural related bleeding and non-procedural related bleeding, they're about the same. I'll show that here. So when you look at overall bleeding, sorry, that should be overall bleeding, there's really no difference. When you look at non-procedural bleeding, it reduces the risk of bleeding. You know, this study is also not perfect. They ended up having a lot lower event rates than they were expecting, and they still used this absolute non-inferiority margin of 4.8%. And from a statistical perspective, this kind of allows you to have a higher chance of still being non-inferior and having a positive trial. So that maybe should have been changed. And as I pointed out, stroke was numerically higher in patients with left atrial appendage occlusion. And some people have said, you know, the absolute number, the risk is nothing to worry about. Maybe it's by chance. I just don't think we have enough data yet. It equates, if you believe those numbers, it equates to about a 0.3% per year higher risk of stroke. And for some patients, maybe that's not a lot. In many of the patients that I've talked to, any increased risk of stroke, it for them is prohibitive. They often decide just to stay on their anticoagulation. So these devices are improving, operator experience is improving even within these studies. But I think we need more data. I really think that if you put in a left atrial appendage, the longer you follow these patients, the lower the chance of bleeding is going to be. I think bleeding will be a win. To me, that's a no-brainer. I still don't know if stroke is going to win in these patients, and I think that is one of the most, if not the most important outcome that patients care about. And I kind of think about this, you know, maybe stroke will be less in the long term. You put in an appendage occlusion device, and if 90% of strokes come from the left atrial appendage, then you have permanent 90% protection. An oral anticoagulation, while you're taking it, should give you, 100% protection, but that's only while you're taking it. These patients that we follow, they have to go for procedures. They have, minor bleeding. They forget their pills, and so which of those will win? I don't know yet. So the last one, recent important trial. So, while you're in there doing my ablation, Dr. Aiden, can you just put in a left atrial appendage closure device? You're going to be in there anyway. I'm going to be asleep anyway. It makes sense. So there was a trial. This was actually published before all of these. So this was the option trial. It was an industry-sponsored RCT, 1-to-1 of ablation plus a Watchman device, or ablation plus continuing your DOAC. 106 sites participated. They looked at a high stroke risk population, chance of ASC 2 or more, 3 or more in females. They had to have non-valvular atrial fibrillation ablation in either the prior 90 to 100 days before the closure, or planned in the following 10 days. So it was designed as you could do that procedure at the exact same time as your ablation. And about 50% of patients had that done. They excluded patients who had a recent event, if they had other reasons for stroke, high-risk PFO, bad LV function, if they had a pericardial effusion beforehand, and if they had a complex intraatrial septum, like they had a prior surgical repair. They looked purely at a non-procedural major bleeding, and they looked at that from a superiority perspective. And then they had another primary efficacy endpoint of death from any cause, stroke, systemic embolism at 3 years. And they looked at that as a non-inferiority. They had 82 patients cross over to the device after they had an event. And about 85% of patients in the DOAC group continued to receive anticoagulation. Some of these stopped because they crossed over to the device. there's almost a 99% successful device implantation. They had a 2% device-related thrombus rate at 12 months, and they said that 80% of patients had complete left atrial appendage closure. You know, I think our numbers are better than that. Some of this is very small leak that is probably not important, but complete perfect results are achievable in about 80%. Patients in this study, they were about 70, predominantly male. Their CHADS VAS score on average was 3.5, so a relatively high stroke risk population. And their Has blood score was only 1, so not particularly high risk for bleeding. So their primary safety endpoint met the superiority of non-procedural related bleeding. This was much higher in the anticoagulation group than it was in the appendage closure group. There was no difference in ischemic stroke or systemic embolism, but event rates were pretty low. And as I've mentioned before, I've harped on, there are complications from this device. So they reported serious device-related adverse events, just under 1%, and left atrial appendage closure-related adverse events, 2.8%. So we always tell patients kind of 2 to 4% risk of complications from appendage closure. Some potential problems with this study. So they had low risk patients with low event rates, and they included all-cause mortality in their primary endpoint. This is not necessarily related to strokes, and so the more of something that's unrelated to your device that you have in your primary endpoint in a non-inferiority style, the more likely you're going to find non-inferiority. And they excluded peri-procedural bleeding in their primary endpoint, which I think if you're going to compare therapy to therapy, that has to go into it goes into the discussion of patients, so it should go into the trials. So I've presented 3 different approaches to patients in getting them off of their anticoagulation. You can ablate them in those low risk patients. Maybe you can stop their anticoagulation. You can put in an appendage closure device, which comes with that risk. And in some places, I don't think here necessarily yet, but during your ablation, you can have your left atrial appendage closure device put in. I recently went to a course where there is an electrophysiologist who that's what they do now in the US for most patients. There's a kind of a fee code for it for doing a concomitant procedure. And it's pretty slick. They do a PFA ablation through the same catheter. You put your Watchman in. And I think patients really like that. I don't think that right now the Canadian system can afford it. I don't think we have the infrastructure to offer this to all patients, especially without more compelling data that it's at least as good or hopefully better than long-term oral anticoagulation. So kind of to summarize, I think that in very highly selected low-risk patients, you might be able to stop their anticoagulation after a successful ablation. But I think that this is a patient-to-patient discussion, and I will personally use caution in patients who are higher risk of stroke. I think, as we already know, oral anticoagulation with DOACs are really effective in reducing stroke risk and in general have relatively low risk of bleeding. Procedures come with risk. So if you're referring patients for procedures, whether it's TAVI, whether it's left atrial appendage closure, whether it's cath, remember that it's not a black box. All of these things come with risk. Your patient should know about that when you counsel them kind of preliminarily, because we will counsel them on that. And I think that this procedural risk should be included in the clinical trials. And to kind of summarize left atrial appendage closure, I don't think we yet have definitive data to say that they're equivalent, even in these really high risk patients. So right now, I think the indication, at least in Canada, is still predominantly patients who cannot tolerate their anticoagulation because they have no other option. There are more trials coming soon. In the next year or two, we'll have Catalyst, which is similar to Champion. And maybe with the combined data, we'll then know if they're equivalent and can offer this to all patients. I'm going to leave you with one last thing. So the Heart Institute is participating in LEOS 4. This is a randomized trial of patients with atrial fibrillation who are high risk for stroke. So they're either a CHA2DS2-VASc 4 or more. They can be treated with anticoagulation, and they have either permanent or persistent atrial fibrillation, or if they have paroxysmal, they've had a prior stroke. And this is a trial where they're randomizing to usual care with oral anticoagulation versus left atrial appendage closure and oral anticoagulation. So trying to give these patients the highest protection from stroke. We're randomizing patients here, and so we're always looking for them. So you can refer them, these patients, if you think that they might like a left atrial appendage device in addition to their anticoagulation, refer them to any of the structural group here. Happy to have a discussion about these.
Thanks. That was excellent. Just come closer to the microphone because our mobile microphone is not working. This is a very hot topic, and I have to ask some questions to start the debate. I think to your question to me, I offer the left atrial appendage operation at the same time of ablation. I wouldn't, because I don't feel like I have a very strong evidence for it at this point. A couple of questions again, just to start the debate. When the closure AF study came in, the major criticism was this used old generation devices and unexperienced centers.
Yeah.
And now the champion AF, I think, uses the more modern device, the experienced operators. A couple of things to ask. One, to me, the debate going around, it looks like it didn't do its intended job. It looks like there's more strokes there, although a little less bleeding, but it seems like from the numbers, you're getting 27 more strokes, prevent for bleeding. What do you think about this? That's my first question. The second one is the endpoints include that the cardiovascular, which is not mostly affected by both of these interventions, which also said that it's diluted the other events, and then most not very limited. And then my other question is, I think the procedural bleeding is also an important part of the risks of the procedure, which is not included. Just a comment that just to start the debate.
Yeah, I think the stroke piece, the events were low, so I don't know if that was just chance. If you had 10,000 patients in the study, are they going to be the same? I don't know, but I think you have in these patients, you're trying to prevent stroke, and so if you have data saying maybe this risk of stroke is a little bit higher, I think if our system, we had an infinite amount of money and we allowed patients to pick, do you want to be on an anticoagulation or do you want to have a procedure? You would have to tell them that the procedure, the left atrial appendage closure, may not protect you from stroke as well based on the data that we have now. When patients get referred, so really common in the structural clinic, lots of nosebleeds. I'm having lots of nosebleeds. I've never had to go to the emergency department for them. My doctor said I can just get this device and my nosebleeds will go away. I can stop my apixaban. Almost entirely when I then tell these patients that if you continue your apixaban, yes, you'll have some nosebleeds. They're manageable. Versus if we put an appendage closure device in and your risk of stroke is higher, almost entirely patients go, oh, I didn't know that. I don't want that. I don't want a stroke. I'm good on my anticoagulation. I'll manage. So I think that, if we had an infinite amount of money in these devices and patients could choose, I think you would have to tell them that. And I think right now, until we have data that says they're the same, I wouldn't push patients to have this device. But I think we need more data. The risk when you break it down into a per year risk, it's relatively low, 0.3% increase your risk of stroke per year, but stroke is devastating. And so I think any increased risk is not good for patients, especially in our system. These, to answer your other questions kind of combined, I think that these studies, you always have to look, is it investigator initiated? Is it company sponsored? And whenever these trials are sponsored, you don't put, however many millions of dollars into your trial to get a negative trial. So they're designed in a way, they know the outcome already. They have data on these patients, so they know their outcome, and so they're going to design it in a way where they can win or show non-inferiority. So I think all of these little strategies you have to be weary of, not including peri-procedural related bleeding, which is part of your therapy. I think is intentionally can be misleading to patients and physicians that kind of don't read the fine print. So I think that those should be accounted for. And when you're designing these studies, you want to design them, you want to have your endpoints have enough events so that you have as much power as you can. So it's hard to get away from including things, that are important: cardiovascular death, all-cause death in your endpoints, but it can sometimes, if you don't then have a lot of endpoints in what matters, stroke, then it can dilute your power to know, is there a true signal there? Dr. Chong. Yeah. So we don't have a microphone. So Dr. Chong was just saying that um, although we see 90% of clots form in the left atrial appendage, that doesn't necessarily directly relate to 90% of strokes coming from there. And he was sort of echoing and making sure that we see that these are highly selected patients who have small left atriums, and once you have a massive left atrium, big left atrial appendage, smoke, your stroke substrate is different than the patients that were included in most of these trials. Um, you know, I'll sort of echo that. Dr. Labanez quizzed me on the other day on what would I do for this patient. It was a patient who they were having some kind of minor, I think it was epistaxis. They had severe MAC, and they were referred for left atrial appendage closure. And he said, "What would you do? Would you offer it?" I said, "Well, nosebleeds, not really. I don't think I would. I'd have to kind of assess the patient." And he said, "What if you close the appendage and now that anticoagulation was preventing thrombus from forming on their horrible MAC? You may actually, in that patient, increase their risk of stroke." And so again, these are really highly selected patients. They didn't have structural valve disease, so probably somebody with really bad MAC, bad caseating MAC, that wouldn't have been included. So, these are highly selected patient populations for a reason, to hopefully have really kind of crisp data and a positive result.
In truly low risk paroxysmal atrial fibrillation patients, the stroke risk is low, irrespective of ablation. And does this explain the result of OCEAN?
Yeah, so thank you for pointing that out. So let me go back to a slide. So I found it interesting Okay, so I didn't really touch on this. So patients in both alone um, uh, and ocean, a lot of them had a CHA2DS2-VASc score of 1 and 2. And in the American guidelines, they say kind of your threshold to anticoagulate somebody is when their annual stroke risk is greater than at least 1 to 2%. So patients with a CHA, and I don't know the proportion of males and females here, but if your CHA2DS2-VASc score is 1, you might not actually anticoagulate that patient. If your CHA2DS2-VASc score is 2 and you're a female, again, the stroke risk is really low. And so they took a very low risk population, which many of those patients, irrespective of ablation, you might not actually anticoagulate. And so, I think maybe that was kind of missed. Maybe that was just to keep their inclusion criteria simple in both of these studies. But I do think it dilutes out your event rates and may make, because of low event rates, then you have a kind of equal or equivocal result. So I think that's an important factor. In Canada, we use CHAD 65. And so it's just, if you're CHAD 65, if you have a point or you're over 65, you get anticoagulated. And so, whether should you use CHA2DS2-VASc, should you use CHADS? I think if you're talking about stopping anticoagulation after an ablation, or I would use CHA2DS2-VASc because that's where we have that data. But many of these patients maybe didn't need to be anticoagulated in the first place anyway. And the other thing is, all of these trials, of the ablation trials, these are patients who are going for an ablation for another clinical reason. So it's to control their symptom burden. And so this isn't something, I wouldn't apply this to a patient. Oh, you have AFib, you're not really symptomatic. You have one episode every 4 years. Hey, we can stop your blood thinner by sending you for a procedure to do the ablation. I don't think that's the right way to think about it. I think this has to be clinically indicated ablation, which I think for most patients, if you have symptomatic AFib, paroxysmal, ablation is a great strategy. And with the new technologies, it's getting safer and safer. So I think it's a great first line treatment for these patients, but I wouldn't do the opposite to do an ablation so that you can stop your anticoagulation, because that's not how the data has come out.
So ask some questions from the floor. Same as I asked.
Yep.
Uh, Thank you very much. I am getting a lot of texts saying that this was an excellent coverage of the topic, not biased to any one of the sites. Great, thank you.
Thank you.